of cardiogenic shock. Also, Research Services has sent out the first announcement to register for grand rounds for distinguished speakers for the months of December, January, and February. So that email went out yesterday. So please sign up for grand rounds. And we've got a couple distinguished speakers that are coming in person from various locations within North America. So if you are present and can attend in person, that would be great for visiting faculty. Okay, it's my pleasure to get on with rounds today. Today, Dr. Ruth McPherson is going to be giving us a presentation on targeting inflammation and cardiovascular disease. Dr. McPherson received her PhD from the University of London and her MD specialty training in internal medicine, endocrinology, and metabolism at the University of Toronto. She's held academic positions at the University of Toronto and McGill University before joining us in 1992. Her laboratory research is centered on understanding genetics and genomics of coronary artery disease. She's published over 270 manuscripts in peer-reviewed journals and was elected to the fellowship in the Royal Society of Canada in 2014. She's our director of the Lipid Clinic, Atherogenomics Lab, and the Ruddy Canadian Cardiovascular Genetics Center. So it is my pleasure to welcome her today, and we always look forward to her presentations, which have historically been exceptional. So thank you so much, Ruth.
Thank you so much, Ellie. And no, I'm not talking about lipids this morning. And I'm probably not an expert in inflammation, but I think it's a topic that that really is important. And I've said from canakinumab to colchicine, actually statins are a very effective anti-inflammatory agent. And of course, we use them all the time. This one, yeah. Those are my disclosures. Okay, so we're going to talk about the role of inflammation in atherosclerotic cardiovascular disease. Because I do genetics, we have to have a few slides of genetics, but definitely there are genetic data that strongly supports the fact that inflammation is actually a causative risk factor in atherosclerosis. Then we'll talk about the clinical trials, the focus on colchicine, and a little bit about the practical application of colchicine in the clinic. Okay, so this goes back to, I remember this paper in 1999, and I'm sure most of our residents were still toddlers when this came out. But when Russell Ross published this paper, it was a review article in the New England Journal of Medicine. It was, you know, kind of paradigm shifting because really the emphasis has been on LDL, atherogenic lipoproteins. And of course, these are definitely part of the, this thing isn't working. You really have to get cholesterol into the subendothelial space. So these lipoproteins become oxidized, but the response to that is a strong inflammatory process that really potentiates atherosclerosis and really closely related to end clinical events such as plaque rupture. So my lab has been very active in genome-wide association studies for coronary disease. This, of course, done with many other groups around the world. And over the course of the last 20 years, we've identified approximately 300 common genetic variants that are significantly associated with coronary disease, atherosclerosis per se, or MI in particular. And there are lots of these. And each of these genetic variants, with exception of lipoprotein A and 9p21, have a small effect, but cumulatively they have a large effect. So the only thing I want to point out is, of course, this involves many processes from lipoproteins to thrombosis, certainly the vascular wall, vascular remodeling, the integrity of the extracellular matrix, but clearly some of the most significant SNPs regulated inflammation, innate immunity. So this is my lab has worked with many of these, and one of my PhD students is now working in CARDS1, which is a very interesting protein that we've shown to have significant anti-inflammatory effects. So suffice to say, there is a genetic relationship there. When these are also data from my lab a few years ago, when you take the SNPs that are associated with coronary disease and you do this multilinear modeling for heritability enrichment, what we find is that the genes involved in inflammation account for about 1/5 of SNP-based heritability. If we so these are those that are involved in the central nervous system development, although very closely related to obesity, are not really so significantly associated with coronary disease. And then, of course, we have Mendelian randomization, which everybody thinks is difficult. It's actually very simple. So if you have genetic variants that are associated with a biomarker, that biomarker is positively related to phenotype, then these SNPs are associated with both the biomarker and the disease, and that is true for the interleukin-6 receptor. So interleukin-6 is one of the most important inflammatory biomarkers, and interleukin-6 receptor, there are some relatively common SNPs that do have an influence there. So those are the genetic data, and move on to the clinical part. So we actually have a lot of data on agents that we use already. So the statins have a pretty potent anti-inflammatory effect. And I'm just giving examples here. So rosuvastatin 20 milligrams used in the Jupiter study, that dose lowered CRP by 37%. So I should make the point, we don't think CRP is a causative inflammatory marker, but it's downstream of IL-6. So it's certainly a marker of inflammation. Ezetimibe, obviously weaker LDL lowering effect by itself, about a 6% decrease in CRP. But when you add it to a statin, as we normally do in the clinic, patients are on a statin plus ezetimibe, you get about another 10% further decrease in CRP. So the two together can be fairly effective. Bempedoic acid, not available in Canada. Some of you saw the CLEAR study that was presented at the ACC. So bempedoic acid acts upstream of HMG-CoA reductase. CLEAR was a study where they took patients who didn't tolerate a statin and put them on bempedoic acid, 15% reduction in LDL, but a pretty potent effect on CRP, and there was a significant effect on MACE outcomes, although less than a statin, but not available, but certainly an interesting agent. The PCSK9 inhibitors, we use them all the time, but they are not anti-inflammatory. We don't see any effect on CRP or other inflammatory markers. And finally, IPE or Vascepa. So it's kind of been sort of marketed as having a bunch of effects, including an anti-inflammatory effect. So in the REDUCE-IT study, reduced CRP by about 13%, so much less than a statin. But difficult to interpret these data because in REDUCE-IT, they compared IPE to a mineral oil placebo, in which there was a 30% increase in CRP. So even though Vascepa is in the Canadian guidelines, we're a little bit uncertain as to how to interpret that study at the moment, because is Vascepa protective because it has direct effects, or was it simply because the mineral oil placebo increased interleukin-6, really important inflammatory cytokine, interleukin-1 beta went way up. So perhaps the perceived benefit of Vascepa was really just that the placebo has some deleterious effects. So, okay, so most of the targets we've been working on to reduce inflammation in the vessel wall target the NOD-like protein 3, the NLRP3 inflammasome. So this is very central to innate immunity, and it is a signaling pathway that eventually results in production of IL-18, IL-1 beta, IL-6, and downstream of that, CRP as a marker. So there had been an NLRP3 inhibitors. There are still some in the works. Interleukin-18 inhibitors have not gone very far. Interleukin-6 inhibitors And some of these are still in development. Interleukin-1 inhibitors, anakinra, there are some data. It's undergoing a clinical trial now, may turn out to be interesting. And finally, we have an old drug that we've used for many years for obviously pericarditis, gout, Mediterranean fever. What colchicine does is to inhibit the polarization of microtubules. So there's a bunch of downstream effects which make it very useful in a number of phenotypes, other phenotypes other than atherosclerosis in cardiology. So by inhibiting polymerization of the microtubule, you're basically blocking, to a certain extent, this whole inflammatory pathway. So what are the trials? Well, CANTOS, canakinumab, target monoclonal antibody inhibiting binding to interleukin-1 beta, so was very effective. There was a CERT trial of methotrexate, which affects purogenic signaling. And then we've had a bunch of important trials, most important being Colcot and Lodoco-2 for colchicine and really this upstream pathway by which inflammation is reduced. So canakinumab, big problem, very expensive drug, although perhaps it could have been less expensive. So it was tested in CANTOS. So these were patients who had a history of an MI, CRP greater or equal to 2. So 2 is the median for the population for CRP. And various doses. These are the data in CRP. Probably can't see that very clearly, but there was up to 7 dose, so really very effective at lowering inflammation. And there was, over a 6-year period, a significant 15% reduction in events. That drug has not been carried forward for atherosclerosis. There was a higher incidence of fatal infections with this drug, although that was small. There was a benefit in terms of non-small cell carcinoma. So actually the drug is perhaps being carried forward for its oncology implications, but is not going to be used for atherosclerosis prevention. So methotrexate, also anti-inflammatory purogenic signaling, and that was tested in the CERT trial, about 5,000 individuals with a history of a MI or multivessel disease with diabetes or metabolic syndrome. So they tested methotrexate 10 to 20 milligrams weekly with the addition of folic acid. The net result was nil. No benefit. But what's important here, there was no effect on interleukin beta, interleukin 6, or CRP. So certainly simply didn't have a sufficient anti-inflammatory effect. And there were sort of downsides. There was an increase in liver enzymes, decrease in leukocytes. There was a small effect in hematocrit, and small increase, but significant in skin cancers. So then we move to colchicine. Colchicine has been around for many years. It was actually used in the Egyptian period for treatment of inflammatory conditions, including gout. They kind of fell in this. So colchicine is derived from the autumn crocus. Trying to find it, autumn crocus. It looked familiar, yes. And really what it does is to inhibit microtubule polymerization. So the net effect of this is on inflammasome, but there are other effects in terms of interference with neutrophil function, interference with platelet production. So actually is now being tested in heart failure and atrial fibrillation. And of course, it's been used for many years in pericarditis, but potential and probably important role in atherosclerosis. So what trials we had? These are the 4 major trials. Colcot, a small initial trial, patients MI in the last 30 days. COPS was an Australian study, a very small study, short follow-up, but patients with ACS and CAD managed either PCI or medical therapy. Lodoco, patients with stable coronary disease, and then Lodoco-2 patients with chronic coronary disease, and this was a much bigger study. Okay, so Colcott, this was led by our colleague Jean-Claude Tardif at the Montreal Heart Institute. Big study, almost 5,000 individuals. So recent MI, within 30 days, they had completed any planned PCI. They were on high-intensity statin. So the dose of colchicine was extended release colchicine, 0.5 milligrams daily or placebo, and the endpoint, composite endpoint CVD, resuscitated arrest, MI stroke, unstable angina, or hospitalization requiring revascularization. And patient characteristics are really not too much to emphasize here. Average age was 60, only 20% were female, but they were basically all on appropriate cardioprotective therapies. So over a period of 42 months, there was a significant decrease in the primary endpoint, and the overall decrease 23%. So what is of interest here is that the curves actually diverge 2 months from randomization, and the curves sort of continue to diverge over the follow-up period. Major clinical outcomes, because hierarchical statistical analysis, but significant for the primary endpoint. What is to note here, there was a Colcott, a very significant decrease in stroke, but the numbers were small. So 5 in the colchicine group, 19 in the placebo group, and 75% decrease, but of course that was only one small study. So when they reanalyzed Colcott, time to treatment. So those individuals who were started treatment within 3 days of the ACS event, really a much more marked decrease in events compared to placebo. So I think the importance of this is, the question is, should all of our patients who come in with ACS be put on colchicine immediately? And that it sort of makes sense, because at the time of an ACS, there is a marked inflammatory response. If you measure CRP, it's literally off the map. But this, of course, was a post-hoc analysis, and there are issues there, but really quite significant. And everything was significant here. Okay. Adverse events. So in Colcott, there was really very little that was different. Some GI side effects, which we know occur with colchicine, but, fairly mild, different, basically 1.8% in the colchicine group, 1% in the placebo group. There was in Colcott, and these were perhaps sicker patients because in post-ACS, there was a significant increase in pneumonia. So, but only 0.9% in the colchicine group, 0.4% in the placebo. So nothing like the fatal septic events that occurred with Encantos with canakinumab. So that's ACS. Perhaps in terms of the number of patients at risk, an important question is, does colchicine have any benefit in patients who have chronic coronary disease? So LODOCA 2 was a follow-up of LODOCA, the smaller study. So LODOCA 2, 5,500 patients, a very soft entry point. Any evidence of coronary disease, including a coronary calcium score greater than 400. So they didn't really need to have had a regular angiography or an event or an intervention. And they were stable for at least 6 months. So garden variety CAD patients. Once again, colchicine 0.5 milligrams versus placebo, primary endpoint, cardiovascular disease, spontaneous MI, ischemic stroke, or ischemia-driven revascularization. Baseline characteristics, very similar to the other studies. Mean age a little higher, 65. Only about 12% were smokers. About 20% had diabetes in each group. And although they were stable, 85% had had a prior ACS. So one might have expected this to be less significant because these were not the patients who were immediately post-event. Nonetheless, there was over a 5-year follow-up period, a very significant decrease in the primary endpoint and the secondary endpoint. So overall, the decrease was about 30%, 0.69. One issue with this trial, I mean, very, very significant outcomes, they didn't measure any inflammatory markers at baseline. So it would have been very interesting to know that amongst these individuals with, quote, stable coronary disease, was there a subset who had a particularly strong beneficial effect to colchicine. So I sit there in the clinic and I see these patients with stable coronary disease for the most part. And is there an indication for colchicine? Is there an indication for colchicine if they're sitting there with a CRP of 5 or 6? And that's something we don't know yet. So LODOCA-2, significant effect on of cardiovascular disease, MI, or ischemic stroke. There was kind of a unsurprising but potent effect on MI or ischemia-driven coronary revasc, and that was 33% reduction, significant at the 0.001 level. So across the board, significant for all cardiovascular endpoints, not significant for death from any cause. Which of course is always something that guidelines want to hang their hat on. Admittedly, these are short studies, so a 5-year follow-up in patients with stable coronary disease isn't really all that long, and you don't expect many patients to die, so a little bit of an issue there. Serious adverse events. Here we didn't see any effect in pneumonia, any effect in infection. We look at the individual adverse events, no difference in new cancers, infection, pneumonia. The hospitalization for GI side effects, no different, even though they complained of that, and no effects on the muscle or no effects on neutropenia. So published in Circ last year, there was a longer follow-up. The results were analyzed by benefit over duration of follow-up. And so from year 4 until the end of the study, we see those curves diverging even more. So that's also important because we put these patients on colchicine. Do we keep them on colchicine forever? Is there, as one does appear, the curves are continuing to diverge. Is there a greater benefit over a longer period of time? And if so, does it apply to all patients with stable coronary disease or to a subset? So obviously conclusions, very neat effect, about a 30% decrease overall in these cardiovascular endpoints. Effects observed early on, but increased over time. And this was despite, standard medical therapy. So all of these patients were obviously on statins, antiplatelet agents, ACE, ARB, etc. Well, the study that had a negative endpoint was COPS. And even though this has been included in the meta-analysis, just want to point out, this is an Australian study. So less than 800 patients post-ACS or stable coronary disease. And once again, colchicine 0.5 milligrams. In this case, it was twice a day, which isn't the dose that's been used in COLCOT or LODOCA-2. So a higher dose and endpoint, which included death, no benefit. So short follow-up, only 1 year, small population, and obviously doesn't have the power of the other studies, but it's out there. That was published. So nice meta-analysis published in the Canadian Journal of Cardiology by the group at the Montreal Heart. That was about a year ago. And they identified 79 studies that had used colchicine, and they retained the 4 that were of high quality. And they analyzed it according to primary and secondary endpoints. And the meta-analysis, really depends on the power of the study, but overall, LODOCA-2, COPS, COLCOT, acute, remember COLCOT is acute ACS, overall a 32% reduction in the primary composite endpoint, and that was significant. For MI, significant Colcott that wasn't individually significant because of the short follow-up, but overall, once again, close to a 38% reduction. Ischemic stroke. So that's kind of interesting. We perhaps didn't really expect that. And this was ischemic stroke, of course, wouldn't apply to other types of stroke, but even for ischemic stroke, a lot of this driven by Colcott in particular, but a very significant decrease. Coronary vasc, once again, significant in the studies individually and across the board. So if you put all these things together, really highly beneficial effects. So is there any concern? I think, we still would like to see mortality data. So all-cause mortality did not decrease. In fact, it was really quite neutral. Non-cardiovascular mortality. So did not increase significantly, but, there's this, and the numbers, the numbers are small. So for example, Lodoca 2, we're talking about a very small number of deaths, 4 versus 5. But the confidence interval was between 0.99 and 1.93. So what does that mean? And, this is probably why it has not been approved by Canada yet, although, I think mortality is always very difficult to assess unless you have extremely long follow-up. What is true is that when they looked at the individual outcomes, individual mortality, nothing was significant. So there was not a significant increase in infections. There was not a significant increase in cancer, in other hospitalization for GI events. So a little bit puzzling and very difficult to know what that means without having really, I think, individual data on who died and why did they die. And we predict those that are at the most benefit for colchicine, but those at most risk. So the Montreal Heart meta-analysis came out at the same time as this meta-analysis from Foley and company in the European Heart Journal, and really very, very similar conclusions. So, I think there's a consensus. So what do we not know? And I think this is important. So patients, of course, were not selected based on CRP or other CVD risk variables in these studies. So once again, really want to know, does everyone benefit or do some people benefit more? So although they didn't measure CRP in Lodoca 2 or the other studies at baseline, at the end of the study in Lodoca 2, there was a 24% lower level of C-reactive protein, and importantly, almost a 15% reduction in interleukin-6, which is a causative inflammatory risk factor. So that is interesting. And of course, is the benefit related to baseline CRP or to another inflammatory marker? This is, just to give you an example, this was reported at the ESC. That was actually August 2022. It hasn't appeared in the press as yet, but a small study, an Israeli study, 1,186 STEMI patients, and they looked at 30-day mortality by CRP and troponin. So for those who had a CRP below the 90th centile, if troponin was less than 33, obviously lower risk, but CRP had an effect on risk patients at a lower level of troponin for patients with higher levels. So we would see that CRP is additive in terms of the risk associated with this other marker of risk at the time of an acute coronary event. So interesting. And of course, our colleague, Paul Ritker, who is the guru of inflammation, published this recently in Lancet. He looked at 3 trials that they're funny trials. One was REDUCE-IT that has some, I think, some caveats, but also the prominent study, which was with a new fibrate, pemafibrate, and the strength study, which studied a combination of EPA and DHA. So the point he made was that at the end of the day, CRP was really a very strong marker of individuals HG and LPL less than 7, so about 1. I said it's CRP less than 2, greatest benefit. But even if LPL can get higher, CRP is lower, they did very well. And those individuals who had the highest levels of CRP, they're at the greatest risk, even for an LPL. Well, difficult study because, you know, it wasn't a statin study and, you know, they weren't on appropriate treatment, but nonetheless, it's out there and got a lot of press. So we also, you know, how does colchicine act at the level of the plaque? And of course, the Cadence study going on now and Ottawa Heart, we know all about this. So I think that's a really interesting study. Cadence is going to provide direct information on the vulnerable plaque using FTG PET. So we're left with this therapeutic hesitancy. So no mortality benefit, but short follow-up. And of course, the early PCSK9 studies, there was no benefit. The long-term follow-up of Fourier, there is mortality benefit, but they had to go for a total of 8 years to see that. So obviously we need longer studies. The non-specific increase in mortality, was that just a play of chance? The only thing was significant when they did the analysis at the end of these studies, individuals aged over 65 had significantly higher mortality, but nothing else individually was significant. So we do need more information there on the individuals at risk. And of course, there's a lot of interest in the potential roles for other CV phenotypes. So this was published in JACC very recently. Patients who have heart failure and who have a high level of CRP, much more likely heart failure if CRP is elevated. So there is a study undergoing now in patients in terms of effects on the heart failure benefit. And these are some of the studies that are included here. So recently, there is another study of patients with PCI, patient post-status per se, and Cadence is one of the information. Those are individually fairly small studies, and I think the most important studies will be these. And I'm not sure that either is exactly perfect. So clear synergy is the patient post PCI treatment is a four factor. The rationale of the design for the two things at once. So they're really testing colchicine 0.5 milligrams twice a day, or spirit from lactone patients who have a synergy drug instead. Couple of caveats here is 0.5 to 0.5 was shoot, which is full pot shoot, and seemed to be beneficial, so it's a higher dose and but other facts related to non-cardiovascular death, perhaps that wasn't possible. But anyway, that's it, it's ongoing. This is a trial of patients with ischemic stroke or TIA. And so based on the fact that we see the benefit in terms of stroke. And that is colchicine 0.5 milligrams a day for whole clot type of TK2. So patients with documented CVD who have diabetes, colchicine 0.5 milligrams a day. So sort of an interesting study. I really think it would be beneficial to have another study, just all patients with stable coronary disease, a larger study for a much longer period of time, but that is not happening at the moment. One issue with colchicine is that generic colchicine is like 25 cents a day. Extended release colchicine used in these studies is also an inexpensive drug. It's about 70 cents a day for the 0.5 milligram extended release. So practical information. So I kind of think, will everyone in the room agree, that colchicine, I think we should be considering it as standard of care in ACS based on Colcott and particularly the patients with Colcott were treated very early. Not everybody agrees. I think what's important to point out, there's no clinically meaningful interaction between colchicine and a statin. So in Colcott, 99% of patients were on statins, high-dose statins, but you're going to fight with the pharmacist. So if I prescribe colchicine, the patient is on 40 of Zuva, they tell the patient they can't take colchicine. So, it's still not out there. You do have to avoid it in patients with severe chronic kidney disease. So EGFR less than 30, avoid colchicine. You can ostensibly give a much smaller dose, but I think for those individuals, it's better to be cautious. You do have to use it with some caution in patients who are on strong CYP3A4 inhibitors and things like ketoconazole, erythromycin. To a certain extent, patients who are in cyclosporin, although it can be used probably a smaller dose. And most side effects that patients have had with colchicine are related to the higher doses, which is why I question using a dose of 0.5 milligrams twice a day. The 0.5 milligram extended release dose, better tolerated than just the 0.6 generic. And most patients, in Colcott and Lodopa-2, the dropout rate because of GI side effects was only about 2%. But admittedly, 10% of patients were not enrolled because they had not tolerated colchicine in the past. So it does help to take colchicine with a full glass of water and with food, many things. So there is some recommendation to monitor CBC, liver enzymes, etc. Patients will have this at baseline. Is it really necessary to do it at 1 month? Little depends on the patient, the baseline levels, but the 0.5 milligram dose is really pretty innocuous. So detailed information, I think, interest here. Patients who are on cyclosporin, we think the 0.5 milligram dose is probably. And for patients on these other drugs, certainly avoid it. We don't have many patients on these medications, and may be able to use it for a short period of time, but not generally. Okay. So, of course, most of these data are from the cardiology literature, but there was a kind of a nice review in a very conservative journal, American Journal of Medicine, about a year ago, and they reviewed all the data on the safety of colchicine, a lot of it based on experience in gout, etc. And they really concluded that the clinical benefit in gout and CV cardiovascular disease achieved at low doses do not sustain serum levels above the upper limit of safety when used in patients who don't have advanced renal failure or liver disease, or a few of the medications stated above. And all the data we have really suggests there has not been a signal for cancer, sepsis, cytopenia, or myotoxicity in the data that are out there, a lot of it with the previous use and things such as gout. So where do we stand? Well, Health Canada was one of the first groups to approve low-dose colchicine for cardiovascular disease based on the Colcott study. So that was actually in August 2021. European Medicines Agency approved it in April of this year, US Food and Drug in June of this year, but CADTH has not approved it, so it's not available in OTB, better or worse. And the CCS guidelines, even though we gave a class 1 recommendation for Vascepa based on one less than optimal trial, colchicine wasn't even mentioned. In the recent AHA guidelines for cardiovascular prevention, it was given a class 2B recommendation, so that basically it, may be considered. They weren't ready to go out there and jump on it. I think a lot related to the fact that we don't have data on mortality benefit. So fun slide. I think the issue is that we can do lots of things for these patients who already have coronary disease. Too many things we can add. Of course, obviously we focused on lipid variables for a long period of time, currently patients, but mostly digital. Triglyceride risk, I'm not sure the focus of that. I don't think triglyceride is not unless the knowledge, so it's really all I understand. It's fine. LPA, well, that's the best ages pipeline, and LPA is risk factor. And of course, we have all these great diabetes drugs that have very significant benefits in autoimmune disease and cardiovascular disease. So to be added to this, to a bunch of this, and makes it on full problem to should we be putting just our ACS patients on colchicine, stable coronary disease and colchicine, or should we wait for more data in terms of who will benefit most? So I leave that question to my audience. Thank you.
Thank you, Ruth. That was a great overview. Will you open it up for discussion? So if you have any questions in the audience, let me know. I'll bring you the microphone. Otherwise, you can type your questions into the chat. Maybe I'll just ask one question. So, about 10, 15 years ago, this risk stratification process by measuring HSCRP was a bit more popular. And it kind of fell out of favor a little bit over the last decade. In your opinion, should we be perhaps resurrecting that a little bit and using that to risk stratify patients to try and figure out which people would benefit?
Well, I think so. I mean, I wish we really had these data from the Colcott and other studies, but I think particularly in stable coronary disease, we should be measuring CRP. So when patients are referred to my clinic, I throw CRP in there as one of the measures that we get. And it was popular after the Jupiter study, and the Jupiter was sort of selecting patients, primary prevention patients, no cardiovascular disease, who deserves a statin, and showed a definite benefit. And then it was said, well, there's no point measuring in patients with coronary disease because we're going to treat them anyway. But I think in terms of adding an agent such as colchicine to a statin, it's very helpful to have that. So what do I do in clinic? Saw a patient recently who'd had a 3-vessel bypass, a very thin patient who shouldn't have a high level of CRP, seems to be well. CRP was 11. And, so obviously we're treating his cholesterol, everything else, but that's a patient that I put on extended release colchicine, thinking it probably will be a benefit, but waiting to see.
There's a question in one of the chat boxes. Could you please comment on the relative anti-inflammatory effects of various doses of statins?
Yes. So I just pulling out some numbers. So in Jupiter, a 37% reduction on 20 milligrams of rosuvastatin. With atorvastatin, it's dose dependent, but it's similar. The 80 milligram dose also results in about a 35% reduction in CRP. So the statins are potent anti-inflammatory agents. The less effective statins like pravastatin, obviously a smaller effect. So this may be one reason why we do see a benefit of high-dose statin therapy, particularly post-event, as long as patients tolerate it.
Dr. Bostar.
Dr. McPherson, thanks so much. That was great. Super interesting talk, and obviously of personal interest to me. I appreciate the shout out for Cadence. So for everyone in the audience, Cadence is ongoing right now, 75% enrollment right now. So especially for the residents and folks on the ward, if you see any patients post ACS with diabetes, send them my way and I'll screen them. So I appreciate that. Thanks, Dr. McPherson. So I found the FDA approval interesting for colchicine in that they gave it the exact same, essentially the exact same wording as statins. So obviously lots of lots of evidence for secondary prevention, so patients with established atherosclerotic disease, but they actually they recommended it for primary prevention as well. And I, for I personally don't know of any evidence for primary prevention. I don't know if you know, in your kind of literature review, if you've come across anything, or you know, why they would have given that recommendation.
I also found that surprising because we have no data. We do not have a primary prevention study. I kind of doubt that we will. One reason is nobody's going to pay for it. But yes, very surprising that was thrown in there. The Europeans did not, and then the Canadian Health Canada did not mention primary prevention. But
Great, thank you. If there's more, I have more questions as well. So you know, colchicine is kind of targeting fairly high up, you know, the inflammasome in the inflammatory pathway. There's ongoing trials with more kind of targeted therapies. And you know, there's been trials in the past looking at kind of targeted, you know, IL-6 or IL-1 beta. Ziltivekimab, I may be mispronouncing that, is, you know, one that's ongoing, and especially, you know, for our heart failure colleagues, I think there's ongoing trials looking at ziltivekimab in heart failure. I'm just wondering, you know, in your opinion, do you think that colchicine will be the anti-inflammatory that we settle on, or do you think that, you know, targeting other parts of the pathway will be more beneficial? Well, and I note that, you know, the U.S. Lodoco is now the drug name for colchicine in the U.S. The price jumped from pennies to, you know, $20 a pill.
And it's 76 cents in Canada.
Yeah, exactly.
So we're going to ship it across the border.
Yeah.
I mean, yeah, that's very surprising. Yeah, I mean, the price is obviously an issue. I'm just going to. Really, the point I want to make is that colchicine acts upstream. So by affecting microtubular polymerization, that has effects on the microtubular matrix. And that is believed to have specific benefits in things such as heart failure, both heart failure reduced or preserved ejection fraction. So there may be benefits of colchicine simply related to the microtubule effect that is independent of and additive to the downstream effects on inflammatory cytokines. And that's just, you know, I'm just postulating because, yeah, we don't know. So
great, thank you.
Yeah. Yeah, that price difference is quite extraordinary, but you know, that happens that's happened with many.
That's great. Thank you so much. Thank you everyone for attending in person and for those who joined us online. And again, thank you, Dr. McPherson, for this excellent overview. Have a good day, everybody.
Thank you.